Good afternoon, everybody. I'm Lee Outhwaite, so I have a number of jobs. One of them is I'm Director of Finance of Chesterfield Royal Hospital, which is a medium-sized DGH, about £250 million turnover in the north of Derbyshire. That's one job. Another job, I'm Director of Finance of the Derbyshire SDP, so that looks after about 1.2 million population and spends about £1.6 billion a year. And I'm also a HFMA trustee, and I sit on their Policy and Research Committee and their qualification awarding body. So just on behalf of HFMA, it's very nice to see you here, and hopefully you're deriving a little bit of value from our value conference. So just a bit of a plug for HFMA, I guess. And I never know what I'm going to say when I stand up and do these things, to be really frank, and rest assured, in terms of the compatibility of these three presentations, we've got no idea what the three of us are going to say. So either this will be a beautifully complementary little bit of a tour around population health and thinking a bit more broadly about how cost is consumed across a health system, or it won't. So we'll see how we go. If I do this, will things move on? Green. Yes. Probably. Has anybody seen little maps of where they live? Little coloured-in pictures where we've started to talk about a concept of place below STP level. Has anybody spent some time with their local government colleagues talking about socially determined disease, which is a far bigger influencer of your health and well-being than the 1.6 billion we happen to spend in Derbyshire? When I first got back into Derbyshire, I had a conversation with the Director of Adult Social Care for the county, who said to me, I have no idea where you spend the NHS resource in the county. And it was a factually accurate statement. We're very good in secondary care at observing a patient that arrives in ED, we treat them, we send them home, but we're not so tippity-top at joining together longitudinal data to try and have a conversation about how we tailor and improve and personalise care. So we've been doing some pilot work in Derbyshire, akin to the work that's going on in Kent and in Nottingham. So there's three competing complementary models here of how we do this, and I'm just going to share the Derbyshire story about where are we at in terms of trying to understand far better where is the resource consumed in Derbyshire and that 1.6 billion. So we've committed in Derbyshire to splitting all of our activity, contractual, financial information down to the 8 Derbyshire places on the assumption that it is clinical teams working differently between primary, secondary, social care that will actually make the difference about how we spend that money, which needs to be located far closer to the patient than us just looking at it county-wide. We are splitting that down to place level. We've got a notion of place-based commissioning, and increasingly there's a big coming together of the commissioning space and the provider space, and we're running this work on population health out of the provider sector because we can do the data analysis slightly more easily, strangely, than you can do in the commissioning space, because we're using it for primary care use in terms of tailoring care, in addition to a potential management use. So what have we done? Essentially, what we're trying to do is understand differential resource consumption both by GP practice and care home, and understanding who the high resource consuming patients are, and play that information back to primary care in a way that primary care can understand and go, I know, yeah, they're my 10 patients that consume most resource, and there is no opportunity for me to defragment their care or do something different or care manage and plan for them in a different way. So at a very technical level, we've put together the data from the main providers in Derbyshire, University Hospitals Derby and Burton, ourselves Chesterfield Royal, the Community Trust and the Mental Health Trust, and we've mapped all the data for the out-of-county flows and have started to generate a hypothesis around who are our high resource consuming patients and could we treat and minister to their needs differently. And we're analysing that by GP practice, and we're analysing that by care home, and increasingly we're coming up with coefficients of, based on weighted population in GP's practice, who's a bigger consumer of resource, and without judgment, playing back to general practice and saying, what does that tell us about our opportunity to reach out differently from the acute sector, or socially prescribe in a different way, located in place? With all of this, a lot like PLICs in a single organisation, the big challenge is once you've got this enormous and replenishable haystack of data, is how do you do the needle identification to say, if only we did something with that care home, you would not see 12 acute admissions in the last 12 months of life to rehydrate that patient in an acute setting because we're going to switch on a bit more community provision. Or you would not see, of course, there is an inverse correlation between that general practice's use of secondary care because there's only 2 locum GPs there with a population of 40,000, right next door to a GP's practice that's got 5 full-time GPs with a population of 50,000. Increasingly, we need to start thinking through how we come up with more elegant ways to understand how our healthcare resource is being consumed. And there's a little animation to show what it looks like, which hopefully will now start whirring. So this is a map of Derbyshire. Will it start whirring? Yes. And there's a lot of places starting to look at this now in terms of STP financial resource. So here, of the 1.2 million patients, we've got a record in the 4 providers of about 703,000 patients who've attended one of those organisations. We know the bed days, we can split them down by individual area. We can then start to look at particular conditions and a heat map across Derbyshire that might be suggestive of should we outreach for COPD into that community in a different way. In addition to that, you can drill into this by GP's practice, and you can go how many bed days are consumed there, what particular condition, drill into that in terms of one of the 8 Derbyshire places to really understand how that resource is being consumed. At the moment, I've got a team of GPs reviewing this data to look at what views of this data could be most impactful in terms of changing the way they deliver treatment and care. There's also some out-of-hospital views we're generating to go, what does this mean for some of our ologists when we are looking at the extent to which the patients become more complex and comorbid at the very moment when medicine becomes more subspecialised, and what does that mean about a notion of differential offer into a sort of polyclinic with different specialists for our most complex patients with the most complex needs. The thing that I'm quite excited about then is getting into really understanding differential GP access into secondary care in county and out of county, and the work that we might be able to do with care homes about, for the want of this level of support into your care home, could we prevent these admissions and how? And this is the moment at which my local government and public health colleagues become most animated about this data. Because what we're beginning to show is, in actual fact, a lot of the resource consumption we assume is health-related across the county isn't at all. There are particular pockets of social isolation and socially determined disease that if we were far more aspirant about public health, we would be ministering to that need in a very different way. It gets directors of public health very engaged. It gets secondary care clinicians very engaged, because what they can begin to see is there's an option here for change in treatment and care, so I'm not forced into the situation of that repeat admission. I actually think I can influence that community service, and we can actually start to drill into what's the precise nature of the particular GP practice's needs and requirements and how we might reach out into that. So what we're doing next is playing that back to all of our general practices. Once we've got a good pull from general practice, say this is the sort of data we do need, and I think it's, if we do this well, and we'll describe the Nottingham and Kent experience, it could be quite game-changing about personalisation and tailoring of care. Will that do? Is that about 10 minutes? No, it's a bit shorter, but we can do the Q&A.
You don't have to carry on talking.
Okay, thanks, folks.
No.